Welcome, everyone. We're excited to be here today. In today's session, we're going to define surrogate partner therapy for you, describe how it works and who it can help, and we're going to share the ways that you can adapt these tools to your own respective practices or settings. We have no conflicts to disclose. We thought it would be helpful to share some information about ourselves and our disciplines as context for our presentation. I'm Heather Howard. I'm a sexologist practicing in clinical, educational, and research capacities. And clinical sexology, which is also called sex counseling, is solution-focused, client-centered, and employs an educational model. A sex counselor works as a specialist to help clients figure out how to meet their sexual goals by providing permission, limited information, and specific suggestions, which are the PLIS in the PLISIT model. We refer out to therapists for intensive therapy, which is the IT in the PLISIT model, and that's beyond our scope. Clients learn skills and tools and gain insight needed to meet their goals through education and exercises that take place during counseling sessions and at home. I see folks of all genders and orientations with a wide variety of challenges and complaints, though I do have concentrations in pelvic pain, chronic health, and mobility limitations. I'm often working in collaboration with a multidisciplinary team that includes surrogate partners such as Andrew.
My name is Andrew Heartman. I'm an ISSWSH certified surrogate partner. I have 10 years experience, and I'm also a co-founder of the Surrogate Partner Collective. I work with clients who identify as women or non-binary. Now, in order to give an introduction to what the job of surrogate partner is, I would like to introduce you to this concept of surrogate partner therapy, because the surrogate partner works only in this context. A typical client of surrogate partner therapy has some difficulty in the way they relate to other people. It could be social, it could be sexual, or it could be in the context of intimate relationship. And they haven't been able to resolve this issue through their own life experiences or with verbal therapy alone. A typical client will have one or more of the following characteristics. They may have high amounts of trauma in their past, or they may be dealing with high levels of fear and anxiety, in particular fear of pain, fear of failure. They may have a complete lack of experience. They may not be willing to be authentic and vulnerable in their relationships. They may have a harshly critical self-image or body image that causes them to anticipate rejection everywhere they turn. Or they may have some level of sexual difficulty that they're dealing with. In order to support a client like this, we create a collaboration between three people: a client, a surrogate partner, and a clinician. Surrogate partner therapy is always done in this format, and it's called the triadic model. So the two professionals involved in this have clearly defined roles.
A clinician's role is to evaluate and prepare a client for surrogate partner therapy. We want to determine if a client can potentially meet their goals in another way, or if it seems that surrogate partner therapy will be the most effective way to do so. We also want to ensure that the client is ready and willing to learn how to bake a cake, rather than to expect someone to bake it and for them just to be able to show up and eat it. And we want to ensure that a client can articulate their goals, which helps us to design a program to address their needs. And we'll be doing that collaboratively with the surrogate partner, the client, and the clinician. We also, as a clinician, will explain the arc of the surrogate partner and client relationship, and we'll answer any fears that the client may have prior to engaging with the surrogate partner. Once a client will work with a surrogate partner, we oversee that relationship, and we support both the client and the surrogate partner in that relationship. Finally, the clinician's role is to generalize the relationship that's taking place with the surrogate partner so that clients can see how the work that they're doing in a surrogate partner setting is relevant to all other relationships.
The role of the surrogate partner is very different in contrast. The surrogate partner will partner directly with the client and engage with them in hands-on experiential exercises that help develop skills in the areas of physical and emotional intimacy, as well as overcome anxiety. Part of forming this relationship is so that the surrogate partner can model healthy relationship skills, including vulnerability and authenticity. Now here I've added the shading, a level of shading that indicates when the surrogate partner is involved in this process. And that makes it very clear that the clinician has responsibilities before, during, and after the surrogate.
So the first meeting with the client and the surrogate partner takes place in the clinician's office. It's really important to establish that we will be working together as a team. And often there's going to be an agreement or contract that all three people have together to discuss how they'll be working. And meeting in the office legitimizes the surrogate partner as a clinical partner. And it creates a safe and more comfortable environment for the client to meet the surrogate partner. It's a familiar space. Lots of clients have challenges with first meetings with any partner. And so this gives them a chance to have a supportive environment with a clinician they trust in order to help them to make that first step in a meeting.
After we meet all together for our three-way meeting, then the client alternates between the surrogate partner and the clinician, meeting separately with each of them. Between these meetings, the clinician and the surrogate partner will communicate with each other so that there is open and honest communication between all three members of the team.
Well, I've had the opportunity to witness the transformations that my clients have made working with surrogate partners. I wanted to look to the literature to see what the overall evidence is for this modality. The article by Rosenbaum, Maloney, and Haruti is an excellent review article of the field. And it also discusses ethical considerations in sexual medicine using their model in their Israeli clinic as an example, where surrogate partner therapy is common practice. The article by Ben-Zion et al. Is a retrospective study of cis women with vaginismus. It's the first study that explored the effectiveness of surrogate partner therapy with people who identify as women. And they compared the effectiveness of working with a surrogate partner for vaginismus with doing couples therapy or couple sex therapy for vaginismus. They had 16 couples in the couple therapy group and 16 individuals working with a surrogate partner in the surrogate partner therapy group. They found that the success rate in this study or in this population was higher. It was 100% success rate, and the endpoint was penile vaginal penetrative sex. It was 100% success rate with surrogate partner therapy and only 75% with couples therapy. They did find that the difference was not statistically significant because of the sample size. But they did also find some other differences in the groups, which are that 88% of the people in couples therapy did have concurrent additional treatments during the study, whereas only 44% of the people working with surrogate partners had concurrent treatments. This may be because many of the people who sought surrogate partner therapy had sought it as a last resort after already having many other treatments. But they also found that the average duration of treatment was lower for the surrogate partner therapy group, 4.9 months versus 6.8 months with the couples. That may be because the couples were also working on some of their relationship issues where those challenges weren't present with the surrogate partner therapy group. The largest study published to date is by Daw. Heterosexual cis men were paired with cis women surrogate partners. And they found that the success rate was almost 90% for all cases. There were over 500 people studied, and 489 people completed the study and were available for follow-up. They found that of the common conditions treated, which included erectile difficulty, either primary or secondary, ejaculatory control issues, difficulty with orgasm, and low sexual desire, all groups were found that they were about 85% or more effective with surrogate partners. Whereas they compared this to what they found to be baseline in the field, which is all people treated for all of these conditions. And they saw at the time, the average was about 50% of baseline. So they did find that surrogate partner therapy was very effective for treating these conditions. We mentioned before that a surrogate partner therapy relationship has an arc. So there are these phases that we'll discuss. They are not always distinct. Many times they are overlapping phases, and yet it gives an idea of the direction of the work. So at the beginning of the work, foundations are built, and this includes building rapport with the surrogate partner and building basic relationship skills and relating skills. Phase 2, which is sensuality and intimacy, focuses on the relationship of a client with oneself, the ability to be aware of one's own senses and to build intimacy and closeness with oneself and acceptance with oneself. Once that's built, then mutuality is possible. So taking these same skills, but applying them in a mutual setting and allowing for the flow of energy between two people rather than focusing only on one's own experience. And this is also where eroticism can be introduced. Finally, there will be a conscious closure to the relationship. As Andrew mentioned before, this is a temporary relationship. And so we will help a client begin a relationship, develop the relationship with oneself, build on that and be present to oneself while also attuned to a partner. And finally, to close the relationship when the goals are met. Many clients don't need to go through all of these phases. They may meet their goals in phase 1 or in phases 1 and 2. They may not need phase 3.
Let's go through and take a closer look at each of these phases, beginning with phase 1, where we build the foundations. In this phase, we're developing awareness. We're working with boundaries and consent and communication. I became aware of the importance of this phase early in my practice. I had an appointment with a client, and in the course of that appointment, I asked her if she would like to share a hug. And she said yes, and consented verbally to that. However, later on, she told me that she actually didn't want to hug me at the time. However, she didn't feel comfortable saying no. That made it very clear to me that it's really important to establish a certain foundation right at the beginning. We need to establish that the client has the awareness to know what they want and what they don't want. After we have that awareness, we want to be able to ensure that the client can move toward the things they do want and set boundaries against what they don't want. And the typical way that we do this is through communication. Because these 3 words start with ABC, I've started to call them the ABCs of SPT. We have a number of different tools and exercises that we can use to develop the ABCs in clients. And I'd like to share one of them with you, which is a communication game called May I, Will You? It has that title because these are 2 ways that we can start a direct request with each other. It involves 2 people. One person will make a request of the other, beginning with may I or will you? The other person will respond, and then the first person will say thank you. And then we switch roles so that the other person makes a request. And we continue switching roles and alternating. For example, if I were to do this exercise with Heather, I might ask, will you massage my neck?
No.
Thank you.
May I call you?
No.
Thank you.
I might ask, will you drive to San Francisco and hug me?
No.
Thank you. I like to do may I will you in 4 different phases. In the first phase, all answers are no. This is really important to give someone not only an opportunity to say no, but to hear no in response to their requests, and for that to be okay. After phase 1 can be done with comfort, then we may move on to phase 2, where all responses are yes. After phase 2 can be done with comfort, then we might move on to phase 3, where in response to a request, I would check in with myself and consider whether or not I actually want to do that thing. And then I would answer honestly. After phase 3 can be done with comfort, then we can move on to phase 4, which is just like phase 3. However, if the answer is yes, then we can go ahead and do that thing that was requested. So each of the phases builds upon earlier phases, and it gradually gets more and more realistic. It might take me several weeks or even months to get to phase 4.
So we created these sample requests to help or facilitate people practicing this exercise. I often, when I practice this exercise in clinic, provide these to clients so that they can try questions without having to be too creative the first time around. So I mentioned before that Andrew and I created those questions. Andrew's talking about how he may use this in his clinic, but I also wanted to talk about how you could adapt these exercises and facilitate awareness, communication, and boundaries in your own setting. In a psychosexual clinic and educational setting, it's possible to use the May I Will You game. I have clients practice this all the time, and we go through the phases. Often they do it with me in clinic at first, and then process what it's like to say no, to hear no, to say thank you when our partner answers honestly, even if the answer is no, and to also process what it's like to have cognitive dissonance when we answer something we don't really want to say, and to finally answer honestly as the stakes are getting higher and higher in each phase. So May I Will You is a great thing to be able to do with couples, and it's diagnostic as well as it allows people to get more comfortable with setting boundaries, respecting and hearing boundaries. Some other tools that I may use and that you may be able to use in your settings to promote consent and agency in the clinical setting are as follows. There is a game that I do as well. I call it the Simon Says game, where it's a spatial boundary exercise. And I have one person stand still, imagine their own force field around them, and then to invite their partner to step towards them and to stop. They use their hands, they use nonverbal language as well as verbal, start and stop. And each partner checks in at every step along the way to name what they're feeling in their bodies. And the limit to the boundary is dictated by the body and nothing else. And in addition to asking the partner to take a step forward, they also ask the partner to take a step back and stop, and they notice what the changes are like in their bodies, what it feels like to ask for the step back, and also for the other partner to notice what it feels like to be asked to step forward and back. If at any time it crosses one or the other partner's boundaries, they will stop. Another way to practice boundary exercises or to enforce boundaries or learn how to enforce boundaries is an exercise which is one that someone does alone, which is, this is my body part, that it belongs to me. So this is my hair, it belongs to me. This is my forehead, it belongs to me. These are my eyes, they belong to me, all the way down the body. And this can be really helpful for people to establish for themselves the limits between themselves and the rest of the world, which is their skin. The skin is the way that we begin to learn how we are separate from the rest of the world, even when we're infants. And often when our emotional or physical boundaries have been violated in our lives, we need to reestablish that boundary for ourselves. Another thing I may do with clients is to ask them where they want to sit and where they want me to sit. And I will do that if I notice a client seems really nervous coming into clinic and very hesitant in the space. So I'll give them the agency to decide where they want to be and where they'd like me to be. And that already suggests that they have agency in this relationship and that I'm not the one in power here. Often people have difficulty saying stop or saying no. And so it can be helpful to give them language that's different, that may be more comfortable or more familiar. So I'll often give them the language of a stoplight, green, yellow, and red. That's familiar to people. And they can get accustomed to not only setting the boundary with red, but they can also invite with green and notice when they start feeling discomfort rather than wait until they've reached an absolute boundary by utilizing yellow. Another way to facilitate agency is to give people the chance to physically establish boundaries. When clients do exercises with partners, it can be helpful to give them the option of using a verbal boundary with language or having a more physical boundary, perhaps by redirecting or moving their partner's hand or body part to a different location. Finally, a way to facilitate communication in a clinical or educational setting is to use active listening tools for people to practice repeating what they've heard and letting the speaker hear back, reflected back what was heard to ensure that they're truly communicating what they intend to say. In a medical or exam or physical therapy setting, there are some additional ways to facilitate agency and for clients to be encouraged to set their boundaries and participate in the experience. First of all, it's important to discuss what the exam entails prior to it happening, to ask for consent. And one thing that you can do, just as I described doing in the Simon Says exercise, is ask the client to tell you when to start as well as when to stop. Again, we may have a lot of clients who've never been told it's okay to say stop, and they may not have that language. And so giving them the chance to practice inviting, starting, and stopping lets them know that they are agents in the entire process. And if you get the sense that this client won't have the agency or won't be able to use the word stop, practice it with them in advance. This can be really important for clients who may seem like they're checking out. Any participation that they have in the process may help keep them present to the experience of what's happening with their bodies. Finally, communication is important in this setting as well. And active listening skills are probably things you use all the time, but I just wanted to give this reminder that they're very important for communication and for clients to ensure that they've been heard. Sometimes we can be in a rush and we can hear clients, but for them to hear back what they've said may help really improve their experience and feel like they've really been heard and someone's been there with them. In a research capacity, informed consent is something that you do regularly. That certainly is a form of asking for consent. It can be important also to continue reminding clients that they are consenting and that they can start and stop at any time without any repercussions. I understand that that's usually in the paperwork, but it's important to remind people along the way, and that's a way that they can experience agency. And certainly active listening is a tool that's used in a research setting as well in order to ensure that we are communicating well with participants.
So far, we've been talking about phase 1, awareness, boundaries, and communication. Another part of the work is that we make extensive use of touch, and we actually have physical contact. And I want to invite you to do an exercise that helps people to have embodied awareness. I recommend that you participate in this exercise, but you are at choice. So you can consent whether or not you choose to do this. If you choose to go ahead, I'm going to invite you to find an everyday object in your vicinity. I have some examples here. It might be something as simple as a pen or a marker, a pillow, or a coaster. Practically anything will do. But all that has to happen is you pick an object. What it is not important. And the purpose is to see what kind of sensations you can experience in your body and in your hands in contact with this object. And the hands are a great tool to have those sensations because the hands have more nerve endings than anywhere in the body other than lips and genitals. So the purpose of this exercise is just to allow your hands to feel good and to experience the sensation for no reason whatsoever. The first step, if you're willing, is to assume a relaxed position. So I invite you to take a deep breath and either close your eyes or have a soft focus and just allow yourself to notice every detail that you can about the object. What is rough? What is smooth? What is pointy? What is cold? What is warm? You may also wish to touch the object with parts of your hand other than the fingertips and see if that creates a different sensation with the back of the hand or the fingernails. You may notice that the slower you touch, the more sensations you have. So to see if that happens, I invite you to slow your touch by half. Notice if any of the sensations you're experiencing are pleasurable. Notice if you have any emotional response. Whether or not you do is okay. It's just all about noticing. It's all about being aware. I invite clients to start out touching an object first, because whenever we're touching an object, we're not really concerned about how the object is receiving our touch. So we can then just focus on our own experience. If you've been doing the exercise, then I invite you to come back. If your eyes are closed, open them up. We will move on where Heather will describe how to apply these sorts of exercises in different settings.
In a clinical setting, I'll also facilitate an object sensate focus exercise for clients as a way to develop the skill of embodied awareness. And then I will direct clients to begin touching each other with that same approach, just as Andrew might do in a surrogate partner setting. Many of you are already familiar with sensate focus, and you may even have attended the educational lecture on sensate focus at last year's ISSWSH annual meeting. If you missed it, the speakers have actually written a book about sensate focus in sex therapy, which gives details about how this can be applied in a clinical setting. I highly recommend it. Some other ways to facilitate embodied awareness may be to direct your client to notice other senses in the room. When clients get flooded or overwhelmed, we may need to try and help them calm down their nervous systems. And so giving them something to direct their attention to that is in the room helps them remain present. This is a value of sensate focus. We're directing them to tap into their own wisdom and use their bodies as a resource rather than a liability. This helps them quiet their minds and stay present and manage panic and dissociation. I'll often begin by giving people exercises for sensate focus that have nothing to do with touch. So I may direct them to do a sensual savoring with any of their senses. So in clinic, we may go through their senses and help them identify what they enjoy in each of their senses so that they can go home and savor that. And then I direct them to do a body scan and notice what they're feeling in their body as they're savoring. Directing people's attention to their breath, to breathing, is another way to facilitate embodied awareness. Finally, mindful masturbation is another way that we might facilitate embodied awareness in our clients. Sending them home to practice masturbating by paying attention to what they're experiencing may change the paradigm for them. Often when people are masturbating, they're doing it with a goal in mind and they may be checked out. And when we're helping them learn how to be in their bodies and how to notice sensations in order to use their bodies as a foundation or as a resource, this can be an excellent tool.
Another part of phase 2 has to deal with body image. In our intimate relationships, we get naked physically and emotionally. And the way that we relate to our body and the way that we expect others to relate to our body has a big impact on the way that we relate to others. Now, the sensate focus exercises that we described earlier can have a big impact on the way we see our bodies. Generally, people relate to their bodies by the way they appear visually compared with idealized objects like movie stars. Whereas whenever you close your eyes and notice the sensations that you get from your body, you can get pleasurable sensations regardless of whether you weigh 80 pounds or 400 pounds, regardless of how old you are, regardless of what gender you are. So whenever we start to see our body as a source of pleasure, rather than something that doesn't look the way we want it to, or doesn't look the way others do, then that's the powerful start of a transformation in body image. We go on beyond that to actually do specific body image exercises, one of which is called the mirror exercise. We have a video clip that is going to show you an example of this in actual practice. This was from a TV show called This Is Life with Lisa Lang that aired in September of 2017. A couple important things to know about this exercise. It doesn't create anything. So I've never seen it happen that someone says, oh, I used to feel good about my body, but after doing that exercise, I felt more critical. Instead, what happens is these voices are already inside our heads, and often they're more powerful when they're not being spoken. And sometimes when we voice them aloud, we can actually see how ridiculous they are and how critical we are with ourselves. And so if I can look honestly at my body and my relationship with it, then I'm much more able to be open and share my body with others.
So as Andrew was sharing, in a safe and non-judgmental space, clients have the opportunity to become conscious of the negative narratives and beliefs that they hold. And that allows them to decide if they want to hold on to them or to rewrite some of them. So I wanted to talk about the ways that we can facilitate this improved narrative about body image in our settings. In a psychosexual clinic or educational setting, we can do exercises with our clients or with our students. One may be an eyes closed visualization. In my setting as a clinical sexologist or sexual counselor, I don't have clients remove their clothes. However, I can have them close their eyes and visualize looking in a mirror and doing the same mirror exercise from top to bottom, sharing what they feel about their bodies. I can also continue with an imaginary journey inside. So they've done an examination of the outside of their bodies, and now they examine the inside of their bodies. And I may direct them to different parts of their bodies, such as the seat of their intelligence, or the seat of anxiety, or the seat of sexuality, so that they get a better examination of their bodies. And of course, this is imaginary, but it helps them to have a better understanding of where they hold different feelings and tensions within themselves. Another option is to give my clients journaling exercises. Sometimes that includes journaling with the other hand, the non-dominant hand, which may bring out different perspectives. It may include writing a letter from the body to its owner, giving voice to the body. And this dear owner letter from a neglected part of the body to its owner can be very powerful. Often that neglected part of the body is the genitals. Sometimes it's a part of us that we may have been frustrated with or felt was letting us down or broken. And so giving voice to that body part may allow some healing and some integration. Another way that I may work with clients to promote body image improvement is show the Lisa Ling episode from CNN. And the title of that is Sexual Healing, if you're searching for it. And that can be very helpful for me to show to a client as a model and to go through what they noticed and how that may relate to them. I mentioned earlier doing the "this is my body part, it belongs to me" as a way to reestablish boundaries. Some of my clients like to do this as a regular mantra for self-acceptance. And while we do the exercise, I don't have them add any value judgment. It's simply, this is my body part, it belongs to me. So when people get to their breasts or their genitals, often areas of their bodies that they don't appreciate, by just saying, you don't have to like it, but we're actually talking about accepting it, that often brings about a change and an integration. And some people then start changing the narrative themselves, saying, this is my beautiful body, or this is my strong body part, or this is my, however they want to characterize it. But that's not the way that I assign it to them. In a medical or an exam setting, or in a research setting or education setting, there are other options for improving or facilitating improved body image. One way is to validate pleasure and validate function in a client. Often the medical model validates or focuses only on pain or dysfunction. And so changing that paradigm and utilizing language and asking questions about what is working can be just as important as asking about what's not working. We can also use scales or create scales where a pain scale doesn't have to end at neutral. It could actually continue on to pleasure, so that we can be asking our clients to consider what feels good and what doesn't feel good. Other ways we can facilitate body image improvement are to examine the implied messages about normality that we are sharing in our studies and research questions. Every instrument that we use, every conversation that we have, every model that we show suggests what is normal and acceptable. So examining the implied messages in our studies, in our research questions, in our exam rooms is very important. Many unhelpful messages and narratives, such as those about bodies and attractiveness, come from the culture at large. And we as providers are influenced by those same cultures, and we may also be unaware of the messages we perpetuate. So when we make a practice of examining our own assumptions, attitudes, and beliefs, we have the opportunity to consciously change messaging for our clients, for our patients, for our students, and for our research subjects. Using materials, models, instruments, and images with a variety of bodies can be very helpful for our clients. We should consider the size and shape of the people that we are showing, the age, race, ethnicity, culture, physical ability. Consider, if someone is using a wheelchair or a colostomy bag or an insulin pump or has an amputation. We want to consider the gender spectrum and see if we can use models from a variety of genders. And we also want to show a variety of genitalia. Consider having models of genitalia that are cut and uncut. We want to be able to show a variety of people so that people can see themselves reflected in the models. In this way, we can be helping our clients to feel more normal and more acceptable, which is typically what people want to feel when it comes to their bodies and to sexuality. The message we want to leave our clients is that love and sex are not limited to those with the conventionally attractive bodies.
Another phase of the work involves mutuality and eroticism. And in this phase, any aspect of relationship could be included, including social skills, including physical and emotional intimacy, including arousal, including eroticism. An activity is only included under certain conditions. And the first condition is that it's necessary for that activity to be done in order to reach the goals. The second condition is that what we've done previously has established a suitable foundation that would allow that activity to be corrective. And a big part of the discussion that we have between all three members of the team is whether a client is ready to take the next step. We don't want to be taking behaviors that already aren't working and reinforcing them. Instead, we need to make sure that everything that we do is transformative and healing. As I said before, it is a temporary relationship, and it's for specific objectives and specific therapeutic goals. And that means eventually we get to a point where that relationship is going to end. That brings us to phase 4 of conscious closure. The intention is for the client to get to a point where they have outgrown this form of therapeutic relationship and that they have become an equal with the surrogate partner, where they have become a peer, and that they have then skills and confidence that they can apply then to relationships of their own choosing. I think of surrogate partner therapy as giving the client experience with every phase of the life cycle of relationship, including the ending. And we want clients to realize that relationships can be ended with respect and gratitude. There may be feelings that arise. There may be sadness, there may be grieving, as there is with the end of any relationship. But it's very valuable to know that those feelings can be survived and managed, because we don't want the client to be so afraid of what happens at the end of a relationship that they're not even willing to take the risk to begin a relationship in the first place.
The clinician will stay involved with the client throughout the process and support the client through the closure process and beyond. Many of our clients, as we mentioned, may not need every phase of the surrogate partner therapy arc. Some will close after phase 1 or phase 2. And that often happens because clients have learned the skills that they need or developed the confidence that they need to go out and start dating and bring an organic relationship into the work so that they can continue their learning with a partner that they've met organically. So they may feel that they have, again, outgrown the surrogate partner relationship, and they have that closure with the surrogate partner and continue the work in the practice of a sex counselor or sex therapist. So it's our jobs to help support the client prepare for the closure phase, have the closure, go through the grieving process if that happens, and it sometimes does. Often clients become very attached to their surrogate partners, and surrogate partners often become very attached to their clients as well. And that can be an important component of the work, and something to celebrate that someone's able to develop that attachment. And it can be important to remind our clients that all relationships will end at one time or another. Most relationships, even while we're alive, will end, and being able to manage those endings and make room for something else to come along is important. So as a brief review, Today, we have discussed how to incorporate tools to promote consent and agency in the clinical setting, such as asking your clients to say start and stop. We've discussed exercises that you can perform to facilitate embodied awareness, such as sensate focus. And we've identified a narrative about the body that can improve body image, which is that the body can be seen as a source of pleasure and a resource rather than solely as a visual object or a liability. We hope you've enjoyed this presentation and that you'll be incorporating some of these tools right away in your own settings.
Thank you for having us, and we look forward to any questions.